Hi all, thank you for your time. My name is Dr. Sandeep Pathak, consultant radiologist here at Whipps Cross Hospital, and in the next few minutes I'm going to show you some pictures of hospitalized patients who are very unwell because they have critical problems with their GI tract or hepatobiliary system or kidneys. I will begin with the GI tract. In the GI tract, I am going to concentrate on patients with bowel wall thickening and GI perforation, both of which can make a patient very unwell. Bowel wall thickening is a non-specific finding that can be seen with a wide variety of pathologies. CT will give us more information than plain abdominal film or ultrasound, but one has to consider things like radiation dose and patient stability. Ultrasound and MRI have a role in the pediatric and pregnant populations, and in patients requiring repetitive imaging for chronic conditions. MRI has limited availability, for example, in some patients it's not available out of hours, and it's a long investigation that requires patient compliance. It may not be achievable for some hospitalized patients. We'll start by considering abdominal X-ray and fluoroscopy. Abdominal X-ray is suitable for critically ill patients who are too unstable to transport, but it is a blunt investigation because of poor resolution and superimposed structures. Here we see bowel wall thickening of the transverse colon. It shows infiltration of the wall, resulting in these thumb-like protrusions of the mucosa. Here is a close-up. This darker area is air within the transverse colon, and these arrows are pointing to mucosal thumbprinting. Fluoroscopy has a limited role in the critically ill patient, but can be useful for evaluating fistulas and early leaks. Here, contrast was injected into a sinus opening, showing this tract communicating with the bowel, confirming the fistula. CT has a much more useful role in bowel wall thickening. I do not support the worrying trend of requesting a non-contrast CT or a CT-KUB if you suspect GI pathology. In some places it is seen as a screening tool for abdominal symptoms, but without intravenous contrast we will miss important pathology, as we will not be able to assess hypo or hyperperfusion of bowel and solid organs. If you are concerned about GI pathology, request a CT abdomen and pelvis with contrast. What do we look for in bowel wall thickening to help you make a diagnosis? We look at the length and the sites of bowel wall thickening, and we look at the pattern of enhancement. Let's start with the length and the sites. Diseases differ in how they involve the bowel. Some diseases cause segmental bowel wall thickening and some diffuse. Here is a coronal CT of the abdomen and pelvis. Here we see circumferential thickening of the proximal sigmoid colon. It's less than 5 centimeters long. In short segment disease like this, think tumor. Here is a length of disease of the sigmoid colon. It measures about 10 centimeters. You can see it here with low attenuation within the lumen and a thickened bowel wall. In this kind of length, think diverticular disease or ischemia. In this case, the diverticular gave it away. In longer segments of bowel wall thickening, consider Crohn's disease or lymphoma. Here we see a loop of small bowel, which is longer segment with marked bowel wall thickening and stranding of the adjacent mesentery, otherwise known as a comb sign. This is Crohn's disease of the small bowel. Longer segments of bowel wall thickening tend to be secondary to infection, inflammatory or ischemic processes. Here we see bowel wall thickening of almost the entire colon. This is ulcerative colitis. Here we see the yellow arrows pointed to the lateral wall of the cecum and ascending colon. This is the descending colon. This is the cecum. Think of an ischemic process, particularly if it corresponds to a vascular territory. Let us now look at the pattern of enhancement. These are CT sections across loops of bowel. Look at this first loop of bowel. This shows transmural enhancement. This low attenuation dark area in the center is the lumen. This is the bowel wall. It's very bright in comparison. This is full thickness transmural enhancement, and it's seen in severe active inflammation or with leaky capillaries. Next to it, this is grey enhancement. Again, you can see the lumen, but the wall is greyer, not as inflamed, not florid like the enhancement we saw before. This is in fact enhancement of an annular tumour. Compare this to the water target sign. Here there is edema of the bowel wall, which is this grey area, and then you have this hyper enhancement of the mucosa, which is this inner area, and this is the lumen. There's no surrounding inflammation of the fat. This type of enhancement is seen in pseudomembranous colitis. Next is a cross-section of the bowel whose wall has a similar attenuation to the surrounding fat. This is burnt out Crohn's disease. This is more serious. Here we see pockets of gas within a submucosal location. This is a patient with small bowel infarction. Now let's look at specific clinical entities causing bowel wall thickening. We'll begin with acute mesenteric ischemia. This is a life-threatening condition with a non-specific presentation. A useful clinical feature is severe abdominal pain that is out of proportion to the physical examination findings. Elevated lactate and a metabolic acidosis should strengthen the diagnosis. It has a high overall mortality rate of 60 to 80%, and prompt diagnosis is crucial. The etiologies are occlusive mesenteric ischemia, where the superior mesenteric artery or vein is occluded. Non-occlusive mesenteric ischemia, it describes shock bowel from hypoperfusion. Small vessel disease, related to ischemia that's caused by chemotherapy, radiation or vasculitis. And finally, small bowel obstruction, which increases pressure within the bowel wall and can lead to resistance to blood flow. The risk of ischemia is increased in cases of closed loop obstruction. Here we have a coronal CT of early small bowel infarction following anastomosis. These arrows correspond to metallic anastomotic sutures. We can see dilatation of the small bowel indicating an ileus, an early sign of ischemia. Now compare the enhancement of the wall of the small bowel proximal to the anastomosis with the enhancement of the wall distal to the anastomosis. you can see it's hypoperfused. This is early mesenteric ischemia. This is the balloons on a string appearance of small bowel obstruction. This leads to increased intraluminal pressure and obstruction, causing venous obstruction with resulting bowel wall thickening and edema. Here is a coronal section through the abdomen. What we can see is the venous opacification, but within this superior mesenteric vein we see this very long eccentric filling defect, which is a superior mesenteric vein thrombus. This will result in wall thickening and mesenteric venous engorgement. And it's always worth glancing at the heart when we are reporting these scans, and here we see a left ventricular filling defect consistent with a thrombus throwing off emboli to the superior mesenteric artery. Ischaemic colitis. Ischaemic colitis is the most common form of non-occlusive bowel ischemia. The typically involved segments are watershed areas between the vascular distributions of the superior mesenteric artery and inferior mesenteric artery, i.e. the splenic flexure, or the inferior mesenteric artery and the internal iliac arteries, otherwise the territory of the sigmoid colon. Here we have a coronal CT demonstrating wall thickening and edema of the descending colon. We can also see some mucosal hyperenhancement. This is due to reperfusion injury after low flow states. This is an axial CT through the abdomen, but using lung windows to make gas more conspicuous. Here we can see submucosal gas signifying microperforations of the bowel wall, an ominous sign. Shock bowel. This is an axial contrast enhanced CT of shock bowel after a crush injury. Here we can see the jejunum is thick-walled and fluid-filled and hyper-enhancing. Shock bowel is the intestinal manifestation of hypoperfusion complex occurring in the setting of hypovolemia and hypotension. Hypoperfusion of the bowel leads to third space losses of fluid into the GI tract. The mucosa becomes more permeable and contrast and fluid leak into other bowel wall layers, which we can see here going all the way across. The small bowel findings are often the most prominent CT findings due to the vulnerability of the intestinal mucosa to ischemia. Trauma is the most common cause, as well as cardiac arrest, CNS injury, septic shock, and diabetic ketoacidosis. Infection. Infectious enteritis can be caused by a wide variety of organisms. Patients present with vomiting and or diarrhea, which may be bloody, crampy, and they may also have fever and leukocytosis. Definitive diagnosis requires stool sampling, but some patients get CTs if the diagnosis is unclear. The bowel wall here we can see is thick with prominent folds and thickened colonic haustrations. There is mucosal hyperemia. Sometimes the bowel can be distended and fluid filled. Ileus may develop. Small bowel obstruction is atypical. The distribution of findings can suggest the causative organisms. Giardia tends to involve the proximal small bowel. Yersinia and Salmonella often affect the distal small bowel. TB preferentially involves the terminal ileum. C. diff remains one of the most common hospital-associated infections. Approximately 60% of unwell patients develop a pancolitis with diffuse colonic wall thickening, which we can see here of the descending colon, and this is called the accordion sign. So now I'm going to talk about GI perforation. In GI perforation, initial patient presentation can be non-specific, resulting in a broad differential. This can delay timely management. I'm going to show you some of the direct and indirect imaging findings of perforation. Gastrointestinal tract perforation involving the stomach, duodenum, small intestine or the large bowel occurs as a result of a full-thickness GI wall injury with release of intraluminal content into the peritoneal or retroperitoneal cavity. There are a ton of causes, mainly beginning with I, if you like mnemonics. The clinical presentations vary from mild to severe abdominal pain with or without sepsis. CT is useful because it can help determine the site and the cause of perforation and can also direct management decisions. Does the patient need emergency surgery, or in the case of stable patients with contained perforations, is a more conservative approach indicated? As always, anatomy is important. When looking at a CT, the location of leaked intraluminal content, intraperitoneal versus retroperitoneal, can help localize the perforation site. If the leaked content, air or fluid, is retroperitoneal, think perforated retroperitoneal structures D2, 3, 4, ascending and descending colon, or the distal third of the rectum. If the leaked contents are intraperitoneal, consider the other lumens. Look at the constituents of the leak. If there's more air than fluid, then think stomach or duodenum or large bowel perforation. If there's more fluid than air, then think small bowel perforation. As always, you could start with a quick X-ray. It's cheap and can pick up a large pneumoperitoneum in 50 to 90% of cases if the patient is upright. In an upright X-ray, this is one of the most common signs: air under the hemidiaphragms. You can see the right hemidiaphragm here and the left hemidiaphragm here with large amounts of air beneath both. Beware the fissures of the right lung mimicking air under the diaphragm, and in most cases you're not going to get this much air. It's going to be much more subtle. There's also a Wriggler's sign. This is where air has leaked outside of the lumen and is opposed to the outer wall of the bowel. So you have air on the outside of the bowel wall and air on the inside of the bowel wall, making that bowel wall much more conspicuous. This is called Wriggler's sign. But the problem is radiographs can't localize the perforation site, and as I've said, they are not sensitive for small amounts of air. So most patients with suspected GI perforation go to CT. A portal venous phase CT of the abdomen and pelvis is enough. You don't need positive oral contrast. There is a risk of aspiration or delayed imaging. Reserve oral contrast for special cases like post-surgical cases. Remember to request a CT of the abdomen and pelvis, not just the abdomen. These are the direct signs. Here we have positive oral contrast in an axial CT. We can see the contrast is leaking through this discontinuity in the bowel wall. Extraluminal air is also highly specific. Here is an axial CT. This is the left lobe of the liver. Here is a mesenteric accumulation of air within the anterior abdominal cavity. This is a case of ischemic bowel which subsequently led to perforation. Here we can see submucosal gas within the bowel wall, and this led to portal venous gas. Here we can see gas within the portal vein tributaries within the liver. This is Ischaemic Colitis. Here's feces packing the rectum, and this resulted in ischemic ulceration and perforation because of increased intraluminal wall pressure from impacted stool. Acute appendicitis is the most common abdominal surgical emergency in the world. Here we can see a thick-walled, fluid-filled appendix. This is an appendicolith, and the blue arrow demonstrates a small collection and free gas. Free gas is often seen in children because of an underdeveloped omentum. In adults, an appendix perforation is more likely to be contained. Here we see penetrating Crohn's disease. Here we see another example of penetrating Crohn's disease with thickening of the bowel wall and an adjacent gas and fluid-filled abscess. Indirect signs of GI perforation include bowel wall thickening, abnormal bowel wall enhancement, mesenteric fat infiltration, and free fluid. Okay, so we finished with the GI tract. Let's talk about hepatobiliary dysfunction in the critically ill patient. Acute hepatobiliary dysfunction typically presents with right upper quadrant pain, fever and occasionally jaundice. We're going to look at the imaging modalities that we can use to investigate these and the etiologies. Ultrasound is often the first imaging modality of choice. It's very good for the detection of gallstones. It can be used for the assessment of ductal dilatation or the presence of a fluid collection. It is, however, limited in its ability to identify a cause of these findings. Doppler ultrasound is useful for assessment of hepatic vasculature, particularly important in the post-transplant patients. CT is the most commonly utilized imaging modality to assess acute abdominal pain and plays a major role in the evaluation of acute hepatobiliary disease. It is best formed after the administration of intravenous contrast, when possible, and it's an excellent modality for assessing hepatic parenchyma and adjacent structures. MR imaging offers excellent soft tissue characterization, specifically in evaluating hepatic parenchyma as well as the adjacent organs. Unlike CT, it's also sensitive for detecting gallstones. MRCP may also be performed taking advantage of heavily T2 weighted images to evaluate the biliary tree and obstructions within them. Let's look at the etiologies, beginning with inflammation and/or infection. The first image is an ultrasound image showing acute cholecystitis. It shows gallbladder wall thickening, wall edema, and pericholecystic fluid. Here we see a little pericholecystic abscess, and this is liver parenchyma. The distinct advantage of ultrasound is that it's real time, so it can elicit a sonographic Murphy sign. It may be worth asking whether one can be elicited during an ultrasound examination. CT offers complementary information. and can diagnose acute cholecystitis by identifying a distended gallbladder with wall thickening, wall edema, and pericholecystic stranding. MRI may show similar findings to CT. With the added benefit of this T2 weighted sequence, you can see gallstones layering within the dependent portion of the inflamed gallbladder. It is worth mentioning at this point acute acalculous cholecystitis. This is characterized by gallbladder inflammation without obstruction from gallstones. It often affects critically ill patients, particularly after surgery, trauma, burn injury, and cardiac arrest. Acute acalculous cholecystitis in critically ill patients tends to have a worse prognosis with a mortality rate of up to 50%. Imaging demonstrates similar findings to acute calculous cholecystitis, including gallbladder distension, wall thickening, the things that we see on these imaging, but without the gallstones. Back to acute cholecystitis. This can be complicated by secondary infection of the inflamed gallbladder. Here we see emphysematous cholecystitis. This is where you have superinfection of the gallbladder by a gas-forming organism, and there's eventually a perforation of the gallbladder wall, and here is a collection with gas in it anterior to it. This is the remnant of the gallbladder. It affects diabetics and patients over 40 years old. Here we have a CT scan of what looks like the gallbladder, but note there is a chronic inflammatory process going on here with thickened septations, intramural nodules, and a heterogeneous wall enhancement. This is xanthogranulomatous cholecystitis, sometimes indistinguishable from tumour. A rare complication of gallstones is gallstone ileus. This is characterized by mechanical obstruction of the GI tract secondary to an impacted gallstone. A gallbladder stone erodes into an adjacent bowel loop, causing obstruction, most commonly in the terminal ileum. Here the CT demonstrates dilated bowel loops, pneumobilia, and what we see here is a fistulous connection between the gallbladder, which has air in it, and the duodenum. MRCP is incredibly useful. This is a maximum intensity projection, and here we see fluid is very bright. We can see the gall bladder, we can see the cystic duct. This is the intrahepatic duct anatomy. We can see that the ducts are dilated, and if we follow the common hepatic duct, then the common bile duct downwards, we see these ovoid filling defects within the common bile duct, consistent with common bile duct stones. This thing next to it is the pancreatic duct. Let's talk about vascular causes of hepatobiliary dysfunction. Let's begin with Budd-Chiari syndrome. It comprises several disorders that can cause venous outflow obstruction of the liver, with the most common being a clotting disorder. Malignant causes are also possible, invading the hepatic veins and or the inferior vena cava. In the acute form, CT may demonstrate findings of hepatomegaly, suggesting congestion and decreased attenuation, which may be secondary to edema. Thrombus may also be seen in the hepatic veins. Here is a CT of the liver. There's free fluid around it, but here is an heterogeneously enhancing intrahepatic mass, compressing the hepatic veins with tumor thrombus within the intrahepatic cava. Note this heterogeneous enhancement and diffuse edema of the hepatic parenchyma. Portal venous thrombosis is seen in cirrhotic patients. This is due mainly to factors such as hypercoagulability and reduced portal venous flow. Here we see thrombus in the portal vein extending into the superior mesenteric and splenic veins. It can be asymptomatic. It can be demonstrated with ultrasound, which can show thrombus within the portal vein. Ultrasound may also show absence of flow. Contrast-enhanced CT is often obtained in order to determine the extent of thrombosis. CT also offers the added benefit of assessing the bowel for ischemia in the presence of extensive superior mesenteric venous thrombosis. Here we see thrombus within the intrahepatic portal veins. It's low attenuation branching thrombus expanding the veins. Malignancy presents with symptoms of biliary obstruction or hepatic congestions. Tumours may be primary, most commonly hepatocellular carcinoma or cholangiocarcinoma, metastatic, or directly extend from an adjacent organ. The role of imaging in these cases is to identify the tumour, assess involvement of the biliary tree, and to detect the patency of the hepatic vasculature. Extrahepatic tumours such as cholangiocarcinoma and pancreatic cancer can present with painless jaundice, pruritus, and weight loss. These tumours infiltrate and compress the common bile and/or hepatic ducts, causing upstream duct dilatation. This can be seen on ultrasound, CT, or MRCP. Tumours that are located very distally in the biliary tree can also cause obstruction and dilatation of the pancreatic duct, causing the appearance of a double duct sign. Klatskin tumours are more proximal and are located at the confluence of the left and right hepatic ducts. Tumours at this level cause intrahepatic ductal dilatation, where the common duct remains normal in calibre. Here is a mass in the pancreatic head, obstructing the pancreatic duct, which is this low signal duct within the body of the pancreas, causing dilatation and obstruction. And here is a common bile duct, which is markedly dilated due to obstruction by the pancreatic head tumour. Here is a Klatskin tumour. It's a filling defect tumour on an MRCP obstructing the left and right ducts at their confluence, and here we see the distal CBD, completely fine, normal calibre, not obstructed. Here is a hepatocellular carcinoma, very large enhancing mass occupying almost the entire right lobe of the liver. Let's talk about the postoperative causes of hepatobiliary dysfunction. Postoperative complications can cause hepatobiliary dysfunction. For example, complications of cholecystectomy, including bile leaks and drop stones, retained stones, bleeding, and abscesses. Here we show this is a CT showing a large gas and fluid collection within the gallbladder bed post-cholecystectomy, consistent with an abscess. This is a sagittal CT of the liver. Behind the liver is this thick-walled, fluid-filled abscess, and within the abscess is a calcified gallstone, a dropped stone. Liver transplantation is the first-line treatment of end-stage liver disease. Complications after liver transplantation include rejection, vascular and biliary complications. Hepatic artery thrombosis is the most common post-transplantation vascular complication. Here we show a CT angiography showing a very tight stricture, stenosis at the hepatic artery anastomosis, which was subsequently angioplastied. We're going to end by talking about acute kidney injury. Acute kidney injury is characterized by a decline in the glomerular filtration rate over hours to days. There is an increase in creatinine and sometimes reduced urine output. It is common, affecting up to 20% of hospitalized patients and up to 60% of ICU admissions. The causes, as you know, can be divided into pre-renal, renal and post-renal. Pre-renal causes are the result of hypoperfusion or hypovolemia, including decreased fluid intake, vomiting, diarrhea, blood loss and sepsis. The most common renal cause is acute tubular necrosis. Post-renal causes are obstructive, such as calculi, malignancy and BPH. Untreated, acute kidney injury will lead to uremia, volume overload and electrolyte disturbances. The first choice imaging modality for acute kidney injury is ultrasound. Here we can measure the size of the kidneys, which can help differentiate acute from chronic kidney disease. Here is a very small kidney, indicating chronic kidney disease. It's atrophic. In this case, the patient's renal function is unlikely to fully recover. Here we have an enlarged kidney, which suggests an infiltrative disease process on ultrasound. It may also be a manifestation of pyelonephritis, acute tubular necrosis, or acute interstitial nephritis. On the right-hand side, we have a mild hydronephrosis demonstrated by slight dilatation of the renal pelvis and calyces, and a more severe hydronephrosis. Again, you have caliectasia, dilatation of the renal pelvis. This is the renal cortex. In the context of AKI, this indicates obstruction, and treatment consists of relief of this obstruction by catheter stent or nephrostomy. Ultrasound won't tell us really what the cause of the obstruction is, and this is where CT becomes very useful. CT is the second line imaging after ultrasound. We try and avoid iodinated intravenous contrast, particularly where there is an acute kidney injury. However, the jury is still out, and clinical need should dictate whether we use it or not. Unenhanced CT can detect stones which may be causing obstruction. Here we have a stone in the mid-left ureter, and this is the thickened urothelium and ureter around it. Perinephric stranding can often tell us how sick the kidney is and suggest infection. Here's an axial CT. The right kidney looks absolutely fine. Look at the fat renal parenchyma interface. It's clear, it's crisp. Here on the left we can see hydronephrosis by dilatation of that calyx. And look at all the stranding around that left renal cortex. This is a sick kidney. It probably requires decompressing very quickly. We can do some quite funky things with CT. Here is a 3D reformat. You can see the ureter here, and you can see the obstructing stone within the mid-ureter. And we can go all the way around it, just twist it around. Renal pelvis up here is dilated. Other causes of obstruction may be further downstream. Here is a CT showing bilateral hydronephrosis as depicted by the black arrows with the dilatation of the calyces. And down here in the bladder is this enhancing mass consistent with a transitional cell carcinoma, basically taking out both ureteric orifices, causing hydronephrosis. MRI sequences can provide valuable information in the workup for acute kidney injury. They may be particularly useful for patients who are pregnant, young, or for whom iodinated contrast is contraindicated. Here is a T2 weighted image of the kidneys where fluid is bright. You can see hydronephrosis with this caliectasia. Compare it to the left. Here we can see a low signal filling defect within the proximal left ureter consistent with a stone. Here we can see a diffusion weighted image showing restricted diffusion in this ovoid lesion anterior to the right kidney. Restricted diffusion implies a renal abscess as opposed to a renal cyst. So, thank you for listening to my presentation.